Good evening, everyone, respected seniors and dear colleagues. I think we'll start because we have two big topics today for discussion. So, without wasting time, we have very interesting debates today. So, we'll get more delayed actually. हाँ, let us start. क्योंकि वो चालू होने में 5 मिनट लग जाएंगे और. So, two interesting topics for discussion, both around stones, supine versus prone PCNL and RIRS versus mini PERC. So, we'll start with the debate on PCNL approach for large renal pelvic calculus. So, we have an index case. He is a middle-aged man presented with right-sided flank pain and on investigation found to have a 3.5 centimeter large right inner pelvic calculus with another single lower calaceal calculus. He doesn't have any medical history, no any previous surgical history. So this case will be an index case for our discussion. So I would like to invite both our speakers for this debate. Dr. Aditya Edikar will be speaking in favor of supine PCNL and Dr. Sudarshan Jadhav will speak in favor of prone PCNL. So let us start. Aditya and Sudarshan. I would like to invite Aditya first.
Good evening, everyone. Today's debate, what topic I got was to talk in favor of supine PCNL. So I just got this example on internet. Like it is just depends on your comfort whether you can repair a car from below or you can repair it from above. So originally, supine PCNL was started in 1987 when Valdivia had invented this position where he just used a bolster below the waist or back, you can say, and a small bolster at the shoulder, and the patient was around 15 to 20 degrees tilt and hand was on the opposite side. The surgeon was standing on this side. So after this original position, there were a lot of modification in the supine position. So what was the reason for modification was ease of puncture under the image guidance, which was difficult in the original position. Operative field availability was limited, so they wanted more field, ability to make and dilate multiple tracks, and ease of ECRS is endoscopic combined intrarenal surgery where we can do RIRS and PCNL in the same sitting. Also nowadays they have come out with simultaneous bilateral endoscopic surgery. This was also indication to start supine PCNL. What are the basic indications of supine PCNL are basic. All indications of prone PCNL are can be done in supine PCNL. Special indications are morbidly obese patients, patients with severe respiratory problems like COPD, bronchial asthma, obstructive sleep apneas, who may not tolerate prone position easily. Better accepted in regional anesthesia, especially when the patient needed some more additional anesthesia due to the prolongation of procedure like sedation and all. It is easier for the anesthetist to give in supine as compared to in prone. Then all patients who need ECRS and SBAs, patients who cannot tolerate prone positions for any other reason. So just special reason, last week we did this case. He was a 72 years old male. He had a fractured left neck of femur. He had a AKI which they started IV antibiotics. Creatinine was up to 2.1, which later came down to 1.4. He was diagnosed to have a right upper uretary calculi of 13 to 15 mm. Basically the orthopedician wanted the patient to be stone free so that he can do a implant surgery without any chance of infection. So this was the patient lying in ICU. This X-ray of the hip showing fracture femur. We don't have any actually X-ray and CT, so just the ultrasound report showing right upper ureteric stone. So this was the basic position that we gave him. With very difficulty, even this slide lithotomy position was given to him. Prone was not a option in this case. This is how the puncture needle is there. You can see it is in around 15 to 20 degrees or just parallel to the OT table. This was the endoscopic view. Here you can appreciate, like in supine, usually the PCS is collapsed and you will not find it as roomy as in prone PCNL, but you can appreciate the comfortable sitting position, comfortably the view of the endo camera, and this is the CM. So this is the position where we did a PCNL in supine position for this patient. This was the stone. It was an upper ureteric stone. With difficulty we could push it into the kidney and then removed it intact, the 20 French amplets. The basic advantages of supine PCNL can be divided into 5 factors: the patient factors, anesthesia factors, surgeon related, procedure related, and what the evidences say. Patient factors are less discomfort due to the position, less difficulties in positioning, less manpower needed to reposition the patient. This can save time. Punctures are mostly subcostal in supine cases, relatively lateral punctures, so access to both anterior and posterior calyces is possible, less chance of injury to patient and staff, less catheter displacement and kinking, less anesthesia problem for special cases like respiratory problem cases, morbidly obese cases. Position advantages are there are usually no respiratory compromises in supine position, less chance of neurologic damage. We all know less chances, but there are of course chances of optic nerve brachial plexus injury. There is less chance of compartment syndrome, rhabdomyolysis, less adjacent organ injury in supine position, less ophthalmic ischemic optic neuropathies and central retinal artery occlusion, corneal abrasion, etc. Anesthesia related advantages are no increasing intrathoracic pressure, improved access for cardiovascular and pulmonary management, especially during emergency, less risk of injury to central and peripheral nerves, less risk of thromboembolism due to lack of inferior vena cava compression, improved ventilator associated parameters, especially for obese patients. There is reduced fluid absorption from the irrigation fluid, which is again advantageous for the anesthesia to avoid fluid overload. Prone PCNL increases the risk of single lung ventilation should the endotracheal tube be displaced while the patient is in reposition. There is no need for extra anesthesiologic equipment such as reinforced endotracheal tubes, stabilizing helmets, specialized paddings, which may add additional cost to the procedure. The surgeon related are comfort to the surgeon, because the surgeon is almost every time sitting during a supine PCNL. His shoulders are relaxed and downwards. Less radiation exposure, especially to the hand, because is comparative to the prone position, is standing little away from the fluoroscopy tube. Fixed position of the fluoro machine. Usually, many times in prone, we need to every time move the C-arm backwards, then again come in. In supine position, you are far away from the C-arm, so it can be at the same position while placing the ureteric or while doing the PCNL. Procedure related advantages are adequate operating area. Triangulation and bullseye, both techniques are possible. Again, ECIRS, SBS are possible. Easy approach to upper calyx from the lower calyx is possible in supine PCNL. Less chance of bowel injury. Low PCS pressure in the pelvic calyceal system. Better stone clearance is shown in supine cases. We'll see the references in the later slides. And of course, this all saves a time, so the less over time. So this is one representative picture which shows in prone position, the orientation of the needle is almost vertical. You can this is the prone position. In supine position, the orientation of the needle is little upwards or just parallel to the OT table. So this position helps in simultaneous spontaneous washout of small fragments, and this helps to reduce the intrarenal pressure. So once the intrarenal pressure is reduced, it indirectly impacts in reducing the rate of infection, fever and sepsis. Puncture angle in supine position PCNL is in complete supine, the posterior calyx has a 50-degree angle with the fluoroscopy bed. These are just representative images to understand the technique of supine PCNL. A slight rotation of the patient induces a significant change in this angle so that it becomes almost parallel. So depending on how you acquire number of cases, you can keep the patient in absolute supine, or if you find difficulty initially, you can start with this position where you give a 15 to 20 degree angle for the patient's body with the OT table. So this was a major thing that we used to think that multiple tracks are not possible, but there are many cases in literature where they have done supine PCNL in through all the tracks in the same patient. And actually the question arises in how many cases do we actually need the upper calyceal puncture, where most of the cases we can handle from the lower calyx. So supine PCNL it is easy to do a puncture from the lower calyx. So we will see what the literature says. So this was a study which what they studied was the position of the colon around the kidney. So what they found is they found that the anterior surface of the left kidney, second one along the posterior surface of the left kidney. So basically in supine, and this is the prone, you can appreciate that in supine this is the punctured track, the colon is a bit away as compared to in prone. So this green arrow shows the colon. So in prone, the colon is if you actually see is much closer to the punctured track as compared to the supine. This was a study in Nadiad where they showed supine, the title was Supine PCNL, effective approach to high risk and morbidly obese patients. This was a study of 62 patients, 57 underwent 57 cases were done in GA, 5 were done in epidural anesthesia, 93% had an anesthesia risk of ASA grade 3. This was all cases were done in supine position. They concluded that supine PCNL is an effective and safe procedure in high risk and obese patients and allows simultaneous management of renal and uretral stone. Another study, supine versus prone position during PCNL, a report from the Cross study which was published in 2011 between November 2007 and December 2009. They studied 5,803 patients, 4,637 were done in prone, 1,166 cases were done in supine position. There were total 96 participating global centers in this study. Compared with supine patients, prone patient exhibited higher rates of blood transfusion, that is 6% in prone and 4% in supine cases, and also fever was less in supine cases, 7.6% as compared to 11.1% in prone position. They concluded that patient safety favors supine PCNL. Another study of total tubeless ultra mini supine PCNL feasibility study. This was from India only by Sandeep Gupta. They studied cases from January 2017 to July. Calculus limited to either a single calyx or just extending to the pelvis were included in this study. Stone size was less than 2 cm. 8.5 French operating nephroscope was used and laser were used for fragmentation. 14 patients were included in the study. There were no complications and 93.3% was the stone free rate. They concluded that ultra mini PCNL in supine position with a complete tubeless approach for renal stone disease is a safe method for treating low volume stone disease. Another study of supine PCNL by the same author in horseshoe kidneys. This was a small case series but significant. 4 cases were studied who had kidney stones in horseshoe kidneys. So they concluded that supine PCNL in horseshoe kidney provides additional benefit of performing the procedure in a single position, which is known to reduce operating time, less anesthesia related complications and less neuromuscular skeletal injury. Another study by Varde et al. This was a meta-analysis. They included 4 studies, of which 2 were randomized controlled trials and 2 were case control studies. A total 389 patients were included in this meta-analysis. 207 patients were done in prone position, 182 patients were done in supine position. They concluded that supine PCNL showed significantly shorter operating time. Supine PCNL had higher stone-free rate, 83.5% versus 81.6. Both techniques were equally safe. There was no difference in complications like fever and transfusion rates. Another interesting study of supine versus prone PCNL for renal calculi, again a meta-analysis. This was printed in 2016 in Journal of Endourology. They included 13 studies, of which 6 were RCTs, 7 were retrospective studies. Total of 6,881 patients were included in this meta-analysis. They concluded that supine PCNL showed a shorter operative time, lower incidence of blood transfusion. Another very interesting paper, upper calyx approachability through a lower calyx axis, comparison between prone and supine PCNL, and assessment of anatomical factors that may influence it using a three-dimensional computed tomography. So what they observed that in 20% of the cases of prone PCNL, it was possible to approach the upper calyx through a lower calyx, whereas in 80% in supine cases, it was possible to approach the upper calyx through the lower calyx. The difference is because in prone position, the angle between lower and upper calyxes is 84 degrees, whereas it is the obtuse angle of 141 degrees in supine position, which makes it easy to approach the upper calyx from a lower calyx puncture. So this is what we fear most is the colon injury in PCNL. So this study, they studied incidence of posterolateral and retrorenal colon in supine and prone position in PCNL. So they studied basically the computed tomograms of patients in supine and prone position. So they found that retrorenal colon is present in 1.9% of supine PCNL and 10% in prone PCNL. In supine PCNL, actually the colon drops about 2.5 centimeter away from the puncture area or the puncture tract, so which makes it safe in supine PCNL and avoids any colonic injury as compared to prone PCNL. A good meta-analysis again of supine versus prone, 2 RCTs and 2 case control studies which included 389 patients. They concluded that PCNL in supine position took a shorter time than the prone position, but both positions appeared to be equivalent with regard to stone-free rate, complication rate, transfusion rate, fever rate. In brief, PCNL in supine position is as effective and safe as PCNL in the prone position and was an alternate option for removal of renal calculi in PCNL. Another important study of the hemodynamic changes in PCNL, comparative study of hemodynamic, electrolyte and metabolic changes during prone and complete supine PCNL done by Hossein et al. They studied 40 patients, 20 were in supine group and 20 were in prone group. They concluded that complete supine PCNL was more advantageous according to its less hemodynamic changes because it caused less hypotension, less fluid absorption, lesser duration of operation, less bleeding and need for transfusion, better access to urethra, less manipulation of the patient, better control of airways during the operation and possibility of simultaneous PCNL and urethroscopy.
Aditya, I think we are overshooting with the time.
I'll just show the technique of PCNL and conclude. Small 2 videos. There is lot of videos and literature for supine PCNL, but due to the time constraints, we'll directly go to the technique. So the only thing important aspects as in PCNL are the position and puncture. So due to the short time, I have all the videos are shown in the same screen. So this is the position what we give. So usually what we do is on the side where we are doing the PCNL, keep the leg straight or keep a lithotomy stirrup which is hanging parallel to the bed, and the opposite side is in a regular lithotomy or little less than a regular lithotomy. So usually in initial cases we mark this posterior axillary line, the 12th rib and the iliac crest. So the area between this, the iliac crest and the 12th rib is usually the puncture area. Most of the time either your needle is parallel to the table or it is slightly pointing upwards. This was access through the lower calyx. You can appreciate clear urine or fluid draining out. This was the endo view. This was a large stone in the pelvis and extending to the lower calyx of around 24 to 25 mm. Again, the regular steps of PCNL, dilating it serially with telescopic dilators. Again, the dilatation is also usually parallel or facing slightly upwards to the OT table. So the problem usually we anticipate is less space. So what you can see here easily that we have ample of space because we need hardly few centimeters for the puncture and dilatation and to get into the kidney. So this much space is more than enough for a PCNL. So there is no, I think, debate or question that supine has got less space as compared to prone. Placing an amplat sheath. You can appreciate in this video how the stones are coming out spontaneously because of the position of the amplats, which is facing downwards with the gravity. So many fragments will spontaneously come out. And this was the comfortable sitting position. Endo view, CME is usually here. Using a regular pneumatic lithotripter to fragment the stones and removing it with a regular alligator forceps. You can appreciate how much is compared with the prone position. So much water is falling down and less is going in. So it helps to reduce the intrarenal PCS pressure, which can decrease complications of fever, sepsis. You can see even in spite of the nephroscope through the 20 French amplats, this is a 19.8 French nephroscope, so much water is coming out. So hardly there is any intrarenal pressure. Second video. So this was a case where we did from supine PCNL from the upper calyx. So you can see since it was the upper calyx, the direction of the puncture, direction of the dilatation nephroscope is slightly facing more towards the ceiling, and you can see this complete clearance. Usually place a nephrostomy tube. This is the removed calculi. This was the endoscopic view. This patient had a large dilated upper calyx and the stone was isolated only in the upper calyx. There was no extension into pelvis, lower calyx. So we decided to puncture the upper calyx. This was a supracostal puncture, but there were no lung related complications in this case. Complete stone clearance was achieved. Even it be a upper calyceal puncture, there was not much difference appreciated as compared to prone.
Okay, Aditya, I think we will stop. I would like to invite opponent speaker for Aditya, Dr. Sudarshan. Aditya is comfortable with, I think, supine position. Now let us see whether Sudarshan is comfortable with supine or prone. I would request all speakers to please stick to the time because we are already late. So it is a humble request for everyone.
Good evening. Already, thank you Aditya for making such a presentation. But still, you take too much time. And since 25 years, supine promoters are taking a time. But still, only 20% cases are done supine and 80% are prone. As everybody knows, PCNL is indicated for more than 2 cm stone. Traditionally, prone PCNL is done because of familiarity with procedure, larger surface area, potentially more direct approach, shorter tract length, and applicable for all stone sizes. Classic position of prone PCNL was described in 1976. In 1980s, Valdivia described PCNL with patient in supine, and in 1987-88 he reported safe percutaneous access to the kidney with patient in supine position, and 10 years later they published their study. In prone position, Majority of PCNLs are performed with patient in prone position and access is obtained through posterior or posterolateral calyx. Why prone? Kidneys are placed posteriorly or retroperitoneally, so we should go from posterior matter, because lumbar spine is never done in anteriorly. Like this, everybody does posteriorly. Posterior or posterior calyx is well defined, shorter tract length, hence more precise. Upper calyx access easy, larger puncture space, and multiple punctures are easily possible. Again, they are not yet having consensus which position is best. They are confused. Complete supine, so-called Valdivia, modified Valdivia, first mill, etc. Daily one position is coming. Now supine, less puncture space, upper calyx access difficult, longer tract length may lead to kink in glide wire and loss of tract. Another concern in supine PCNL is kidneys are in prone position, kidneys are compressed with abdominal wall forces and operating table, so kidneys are less mobile. While in supine position, hypermobility of kidneys is much concerned, and so that needs counter push and that makes dilatation difficult, and there may the chances of loss of tract. The supine promoters are saying there are ventilation and hemodynamic stability issues in prone position, but with optimal placement of pads and boosters, the prone position may provide better ventilation than supine position. This is by Atkins and et al. This is the line from Campbell textbook. Anesthesia, prone PCNL also can be done under spinal anesthesia or even in GA. There is no any concern for tube displacement because already tube is fixed, then patient is made prone. Even in supine position, most of the time till you put a ureteric catheter, dose is fixed. So you know that whether level is adequate or not, or you can put a endotracheal tube. This is a study that efficacy and safety of PCNL under GA versus spinal anesthesia for prone PCNL, and that suggests that hemodynamic profile and lower cost favors the spinal anesthesia over GA. This is another study. Again, one advantage of prone PCNL is wide puncture space, and hence multiple punctures are easily possible, which are may be indicated for staghorn calculus. Hence, prone PCNL is a wide choice of access sites. Upper pole access is easier when patient is prone, and upper pole puncture has many advantages, including ability to work down the renal axis with minimal torque, as the more mobile lower pole rotates to align with the nephroscope. Upper pole axis indicated for staghorn calculus or stones in horseshoe kidney and facilitate access to multiple lower pole calyces with single tract. Dilatation into the upper pole is easier due to more adherent upper pole gerotospacia, and that limits renal mobility. Supine, it is a narrow puncture space. We are making it narrow and doing our job difficult. Tract length, prone, that is shortest direct part to the kidneys, and hence dilatation is easier. Longer part to the kidneys, that makes chances of glide wire kinking, loss of part during dilatation. PCS room and scope movement, prone we have adequate space and that makes nephroscope movement freely, while PCS is distended with saline and hence easier instrumentation in prone position, while in supine scope movement is restricted due to the age of the table, and PCS is collapsed in supine position, hence instrumentation is difficult, that need to be irrigated from ureteric catheter. This is another study from British Journal of Urology, that which position which is difficult, and they have described ease of dilatation and multiple punctures and ease of puncture. So in all three, that ease of puncture, ease of tract dilatation, multiple punctures, prone is routine, prone is easier, while in all all types of supine positions, that puncture dilatation is longer, difficult, multiple tracts are difficult. ECRS, so called it is real advantage, but in how many patients it needs ECRS? Very few. But still we have answer to this. We can be better with urethra and ureter spared by using this flexible mini nephroscope. This is study by Madhusudan Agrawal and their colleagues, that use of novel flexible mini nephroscope in minimally invasive percutaneous nephrolithotomy, and they have showed that it is an effective adjuvant to minimally invasive PCNL to achieve the high stone clearance rate with minimum morbidity. Outcomes, most important outcomes for any PCNL surgery is efficacy in terms of stone-free rate and operative time, and safety parameters in terms of complication rates. Most of the PCNL, supine PCNL papers describes that fewer rate, operative time, blood transfusion. But stone-free rate is lesser in their terms. So most important is stone-free rate and operative time. This is a study that effect of supine versus prone position on outcomes of Stagon calculus, and results from clinical research office of the Indorological Society study. This is the same study that my supine friend has described, and they have described that fewer and all these complications are lesser. But most important is high stone-free rates are achieved in prone position during PNL for patients with Stagon calculi, and complication rates were similar to both the positions. Another meta-analysis is the supine position superior to the prone position for PCNL, and that's having 2 RCTs and 7 non-RCTs, and 6,000 patients were studied, 4,000 in prone position and 1,400 in supine position, and results were that supine position had significantly lower stone-free rate than in prone position, and there was no difference between the positions regarding the complication rate. Another study, prospective randomized study, that prone versus modified supine position for PCNL, and they have studied 62 patients in prone position and 50 patients in supine position, and that found that no significant difference in complication rate, and stone clearance rate was significantly lower in modified supine position. So conclusion, prone, it is optimum for all cases except morbidly obese and severely cardiorespiratory compromised cases. But still adequate training in both technique is essential for optimum results, and supine is indicated for only this kind of patients which are less than fraction of percentage in the routine practice. Thank you.
Thank you, Sudarshan, for such a nice counteract for Aditya. Now, Aditya, I would like to invite you for a rebuttal session if you have any, or otherwise.
Only 2 points about what was mentioned, that mobility is the issue in supine PCNL. So the options is either to place a guide wire or a ureteric catheter across from the ureter, right, and take it out from the puncture side, so which gives stability to the kidney. And secondly is using your opposite hand to give a stability to the kidney. But practically speaking, in all last 50 cases what I did, there was no practical problem of kidney mobility which can hinder the puncture. Second thing was going to the upper calyx, as there were 2-3 studies which had shown that reaching the upper calyx is easier in supine position as compared to the prone position. And I think stone-free rate, yes, of course, Sudarshan has shown it is higher in some studies, but some studies that I had pointed out or presented, they showed a better stone-free rate in supine PCNL than prone.
Okay. Sudarshan, anything you have to say?
I have few slides.
Yes, please.
Retrorenal column. So, most important question, still it is less popular despite of 25 years old. Only less than 20% of PCNL are doing supine because prone is always superior. Old is gold, proponents are opposing to old, that is gold standard proven since ages. Since 25 years, supine promoters are saying only prone is a mistake. They never telling that supine is superior and superior. Definitely supine is never superior to prone, hence failed to get acceptance since 25 years. Supine is just a passion for status, FB and Insta. Ventilation issues, no. As already told that optimal placement of pads and boosters, there is no problem with ventilation. Prone ventilation is the best ventilation world has experienced. That supine position, every gravitational forces, everything that compresses the lung. Whereas in prone, no effect. This is another world journal, Critical Care Medicine, that efficacy of prone position in ARDS, and that shows that it has beneficial effects on gas exchange, respiratory mechanisms and other parameters. ECRS. Again, only in selected cases where multiple stones are indicated with different calyces, we need second puncture or some extra procedure. Again, this is the answer for ECRS. We can use minimal nephroscope from flexible nephroscope from above. Big concern, retrorenal colon. That this is the only study which is presented all over the country. Operitol, they have studied very old study, 90 prone versus 500 supine cities. And what they found that 1.9% are supine patients having retrorenal colon and 10% having retrorenal colon in prone position. But main problem was lateral colon was considered as a retrorenal, and that was re-evaluated after deletion of these patients, and in prone position they have found only 4.7% as a retrorenal colon. Again, those having retrorenal colon, there was which was found at lower renal poles, involved colon was extensively distended with gas and which can be easily identified during fluoroscopy. So that only about 30% angle, that 30 degree angle, we can easily miss the colon. But there is another study, Brazilian study, to assess the retrorenal colon in PNL in 394 supine cities. They studied only 394 supine studies. And what found? They found that 6.9% supine cities having retrorenal colon. But previous study says it is only 1.9% having supine colon in supine position. So this is such a big difference. Again, although proponents are saying that no colonic injury with supine position, literature does not find any difference in colonic injury in supine or prone position. Take home message that we should equally careful in preventing colonic injuries, and pre-op assessment with imaging helps in minimizing the colonic injuries. Stone-free rate superior? No. Again, this is the meta-analysis which shows better stone-free rate with prone PCNL. And prone versus modified, this is also randomized prospective study which also says that second stone-free rate is better with prone PCNL. Radiation exposure, agree that effective radiation dose is 1.5 to and 1.3 times fold higher for lens and extremities during prone position. This is Canadian study, but both positions are still well below the recommended limit for professional exposure. Hence, any stone can be removed. When surgeon is happy, patients are happy, no need to change. Prone to stay prone. And when you are thinking of OT staff, anesthesia person and less, then there will be nothing. Only focus on surgeon's comfort, and never standing is a comfort and standing is a hard work and sitting is a comfort. Then surgeon will be, he is not a surgeon. It is only the result of surgery that is the comfort. Thank you. लगी जाती है.
Thank you both the speakers, Aditya and Sudarshan. Now I would like to invite moderator of the session, Dr. Sharad Somani sir, to give his expert comment. We will take questions and answer after his comments.
Hello. Already both speakers have presented their point and all the data and non-academic images to prove their point. So this was just an last minute preparation. Just to begin, prone PCNL has replaced open stone surgery and was a standard of care for many years. However, whenever there is any procedure which is standardized and it is likely to have some issues, then the newer research is always there to reduce complications and to make the procedure more comfortable for patient and surgeons. Multiple modifications have been described for PCNL, right from the procedure related like mini PERC, ultra mini, micro, super PERC to position related. Supine PCNL in itself is a misnomer because it is never a true supine position, it is a modified position. So this was the position which is multiple positions described. Multiple articles as already presented by both speakers. The initial articles used to say the stone clearance of supine PCNL was inferior and more incidence of colonic injuries. All the recent articles say that the stone clearance and complication events rate is same. time required is less, radiation and anesthesia is less, which is obviously there because the position change time is not there. What are the issues with supine PCNL? Training. Most of us are initially, in initial period, we are trained in prone PCNL. So converting to supine is little difficult. However, for those centers where supine is being done routinely and the residents are exposed to that, I think once you are trained in that, that is a good position to do. CM adjustment, as I said, it is not a true supine position. There is always some tilt, and in a 0 degree CM, kidney and pelvis ureter will fall on the spine. So you need to tilt the CM. To get orientation to the puncture, for the person who is trained in prone PCNL, to do a supine PCNL orientation is little difficult. There is always a space constraint between the last rib and the iliac crest. The punctures are usually very much lateral, and because of that there is a more risk of injury to the colon, even though the articles say that the retrorenal colon is less in prone, supine, whatever, but the puncture being lateral, and if multiple additional punctures are required, then there is real difficulty in that. Advantages, yes, of course, time, radiation, fragment extraction is not required because gravity plays a main role. And in the patients where the position issues are there, then definitely supine will score there. So how to go about it? Individualized, case-based, and of course, whatever one is trained to. If a person is doing trained, the system is trained for prone PCNL, can continue with that, and an occasional patient who requires supine position, that can be done. And as Aditya said in his first slide, whatever position one is comfortable, I think that is the way to go about. Thank you.
Thank you, Saras sir, for these wonderful final comments. Thank you, both the speakers. Now we'll directly move to the next debate. Questions we'll take during dinner. I would like to invite Dr. Prashant for his talk. First, we'll have now this debate. We have an index case. He's a middle-aged man presented with left flank pain and on investigation found to have 18 mm lower pole calculus. On CT, the HU is 1200. So considering this index case, we'll start our debate. The first speaker is Dr. Prashant, who will be speaking in favor of mini PERC.
Good evening, everyone. I am going to talk for mini PERC for a 18 millimeter lower calicial calculus. This is the index case as discussed just now. So, before going to that, we should understand what does a patient expect. A patient expects symptom relief, complete stone clearance, no or less painful procedure, single stop solution, early return to work at affordable cost. So what does guideline says? European guideline says whenever there is a lower polar stone, if it is having little favorable anatomy, you should go for SWL. You can go for between 10 to 20, and if it is not having any favorable anatomy, then you can go for endourology, which includes PCNL as well as URS options. So there is nothing clear on the guidelines. So why not mini PERC? So I will definitely prefer mini PERC in this particular case because of straightforward puncture, single step dilatation, on table clearance because of vacuum cleaner effect, less bleeding, low intrarenal pressure, less chance of sepsis, and exit strategy is totally tubeless if it is if there is no bleeding. Then it can be even done day care, no need of any additional procedures, and short operative time. This is a small incision. So there is a meta-analysis by Zhou Guo et al. which they included 14 publications involving 1279 patients, and in which they concluded that mini PCNL offers a significantly higher stone-free rate than RIRS for lower pole renal calculus. Then another study by Zanetti SP et al. They studied different techniques, compared different techniques for the stone management, in which in mini PCNL group they showed 1 month stone free rate at 93.3, and in RIRS group it was 80.3, and the retreatment rate was there in the RIRS group. In the same study, they again pointed out that HB hemoglobin drop, which was seen in the mini PCNL group, was 0.8, which was not significant. Then in a study done by Pan J et al., they also compared this RIRS and mini PCNL, and they showed stone free rate at 4 weeks. In RIRS group it was 71.4%, and whereas in mini PCNL group it was 96.6%, and overall complication also mini PCNL group had only 11.9%, whereas RIRS group had 16.11%. Next question comes is, does size matter? Yes, it does matter. We are talking about mini PERC. We are talking about mini PERC. So mini PERC is 12 French scope, and conventional is track will go up to 26. So Lam et al. They studied these different techniques, and then they came out with a few observations. So in mini PCNL, single step dilatation and and they compared mini PCNL and mini PCNL and RIRS. So mini PCNL and standard conventional PCNL, they found that the most important thing was complication. So transfusion rate was almost 10 to 15%, and in mini PCNL it was less than 1%. Most of the mini PCNL were tubeless also. And when they compared mini PCNL and flexible URS, in this most important thing was the transfusion rate was almost similar, and the cost effectiveness, if you can see here, it was a big plus for the mini PCNL. So comparing mini versus standard PCNL, CME MS et al., they showed almost very less bleeding in the mini PCNL group than the standard PCNL, and many of the mini PCNLs were done tubeless. In the same paper, they compared the mini PCNL and standard PCNL stone free rate, which was comparable, almost same. So this is how in mini PCNL passive stone clearance can be done very easily by vacuum cleaner effect. Next. And mini PCNL at the end of the surgery can look like completely bloodless as here, and we can actually see a complete internal anatomy very nicely. We can see the efflux, and there is no blood, complete bloodless mini PCNL. Next. Yeah. Coming to post-operative renal functional changes, there is a study for this by J. Yoon Jung et al. They studied with the help of DTP at the end of 1 year in RIRS as well as mini PCNL group, and they found out that there is no difference in RIRS and mini PCNL group at the end of 1 year. So ultimately mini PCNL is a win-win situation. So now, why RIRS is not the right option here? Because it needs a pre-stenting, which is an additional procedure, limited stone-free rate, need for retreatment procedures, sepsis risk, And cost effectiveness, yes, it is very important. So coming to complications of RIRS, infective complication of after retrograde intrarenal surgery, in a study by Francesco et al, they concluded the prevalence was 7.7% of infective complications in this RIRS group. The disadvantages of RIRS are scope longevity is less, repair costs are high, insurance reimbursement rates are less, and of course RIRS is a costly affair to maintain. So we all know it requires a lot of money to do RIRS, and there is a lot of recurring cost also for the same. There is an article by Oliver Trexler et al. Regarding the ureteral wall injuries resulting from the insertion of ureteral access sheaths during retrograde intrarenal surgery, in which they concluded ureteral wall injury was found in 167 patients, almost 46.5%, and the severe injury involving the smooth muscle layer was observed in 48 patients, that was 13.3%, which require endoscopic treatment. Similar study done by August Yu and et al, they also graded these injuries because of the access sheath, and if you can see here in the grade 2 or more, in grade 2, which requires endoscopic surgery, are more than 14.5%, which is a significantly high number. Mortality with flexible ureteroscopy. There is a paper by Luca Cindolo et al, in which they studied 6 cases, with 6 urologists reported 6 fatal cases after RIRS. In 3 cases, a history of urinary tract infection was present. 4 patients died of urosepsis, 1 due to an anesthetic and 1 due to hemorrhagic complication. The use of ureteral access sheath was not common that time. So RIRS has some serious complications. So in this particular case, just after the 15 minutes of lasing, this was the scenario. There was a serious bleeding, nightmare for any urologist following removal of the flexible scope, which is really a nightmare. Next. Now I think Rajnikant should think about his RIRS is really safe.
Now, Rajnikant will speak in favor of RIRS for such an index case.
Good evening, everyone. So thank you for this opportunity, Arun sir. I am the David versus Goliath. He is a big guy with so much of experience, and I am somebody new who just 3 years into practice, speaking for a technology that exists not more than 10-15 years ago. That makes it. So I am going to speak for RIRS, and this case given is particularly tricky. It's a 18 mm lower calyceal dense stone. I'm not going to show into the video of this. So he has already described. The present state of guidelines recommend for lower polar stones treatment as endourology. Endourology means whatever that urologist feels perfect for that particular situation. So the ground has not been lost on the RIRS. It has actually started winning. This is the step which we are going to take. So why this debate? Why this all debate that why RIRS, why mini-PERC, why this debate? Many of us would have easily done. I confess that many of us would have already considered this patient for mini-PERC straightforward. Then why this debate? Why we just don't go according to guidelines and do the mini-PERC? Because everyone keeps following guidelines. Who will innovate? Who will think of something new, something more exciting, something better for patient irrespective of what it takes? That's what urologists are. So my stand is not against mini-PERC, but my stand is against misconceptions of RIRS. I am not going to talk against how mini-PERC is bad or how RIRS is good. I am going to talk about what are misconceptions in our mind, our everybody's mind about RIRS. What is preoccupied in our mind? So these are the arguments Prashant sir has put forth against RIRS. Scope won't pass, staged procedures, fragments will remain, the dust will never get cleared, long operative time, stones will not get cleared, it is expensive, Priyanka Chopra, and it's not possible probably in difficult anatomy. He has not covered that. So let me take it one by one. The first argument he said was scope won't pass, the ureters are too narrow, there is a high chance of ureteric injuries, it will definitely require a staged procedure. Now let me go back to way back 18 years in urology history. This is a study in 2005 and it has been supported by Michael Clement. It says the rate of failing to pass without any formal dilatation is 0.9% for 7.4 French ureteroscope. This is way back in 2005. At that time the miniature flexible ureteroscopes were not there. And that means almost 99.1% patients we will be able to pass a flexible ureteroscope in first attempt if it is less than 7.5 French. And we never tried that because its technology is new. So the scope will pass. And as most of you know, the 7 French is here. Some of us are already using it. And as we already know from urolithiasis group's discussion, the 6 French is already in the making. Sooner or later, we'll have a 6 French flexible ureteroscope and we will make PCNL probably history. The next argument, the fragments will remain, dust doesn't get cleared. So now everybody believes that lower calyx is always in dependent position. But when you see in supine position, when the patient is sleeping for almost 8 hours a day, lower calyx is not dependent, it drains. That dust which we make in RIRS actually drains. Now, let me go a step further. With the advent of thulium fiber laser, and let me get very clear to you, all my data is after 2018. I had not included anecdotal studies in any of my thing, except the first one. Everything is fresh, latest evidence, newer guidelines. So this says the thulium fiber laser usage is less likely to be associated with residual fragments. Now, isn't that exciting? We are just stuck in our past that no, it will not cause complete clearance. Come on, man, there is new technology. We can use it, embrace it and make it more clear. Now, this is another study. This is 2023's paper, the fresh paper. It is only available online. Now, it says that with suction in RIRS, there is a higher stone-free rate. There is a reduction in chances of infective complications, which Prashant sir has already mentioned. And probably RIRS with suction is a natural successor of its traditional technique. So we already have something which takes care of dust as well as infection. So this argument holds null. The fragments will get clear, dust will get cleared if you only believe that, if you only think that. Now the next argument is long operative time. So now let me get very clear to you. Whatever data Prashant sir has presented or there is in the right now in PubMed has all the data where RIRS was compared when it was a large size scope with a holmium laser with probably not so great fragmentations and never a great dusting. But with advent of thulium fiber laser, this had changed. So I am going to compare my OR times with respect to holmium lasers because that is the data mini-PERC has been compared always with. There is hardly any data of a thulium fiber laser RIRS with a thulium fiber laser mini-PERC. So now this particular study, this is a prospective RCT, so it's a level 1B evidence. It says that stone free rate at NCCT, it's not X-ray, it's not ultrasound, NCCT at 3-month follow-up is 49% with holmium YAG and 86% with TFL. Now let that sink in. What everybody is comparing mini PERC with RIRS has used most of the time holmium YAG lasers. I accept that was not perfect, but now we have something that is perfect and that works. And even the operative time is shorter. And the bleeding that actually, Prashant sir had shown one video when there is a gross flush of hematuria and everybody would be scared of that. And that is less with TFL because we create a finer dust and water clears that out. So this is another meta-analysis. So it included almost 15 studies with close to 1700 cases, and it shows that operative time, laser under time, and ablation rates were significantly better with TFL than holmium YAG. So we have the correct laser right now for RIRS with us. So the long operative time, it's no more, and if at all it is there, it is during learning curve. How many of us do at least 2 RIRS every day? But many of us do more than 4 PCNLs every day. So that will definitely change as we practice it more. Now the next argument I would like to take on is incomplete clearance. So this is the study which shows that RIRS versus mini PERC with a 10 to 20 millimeter with a thulium fiber lace, that is fiber dust, it is from Quantas. Now let me be clear, Quantas thulium is not as great as that of Olympus or this company. So this study has prospectively compared the stones between 10 to 12 millimeter. It has a comparable stone free rate and a similar complication rate. Now when we go, let's explore the stones more than 2 centimeter. Let's go what been given to us by Arun sir. Now it shows that this study particularly treats the stones, pelvic stones more than 2 centimeters. It's a prospective RCT, and it says that at 6 weeks, the CT scan evaluation stone free rates, 53% of PCNL group had either complete clearance or residual fragment less than 4 millimeter compared to 49 in RIRS group. Now let's go to what is the efficacy of RIRS in lower polar stones. Now this particular study, which is the latest data of 2023, it shows this study is meant for lower polar stones of around size 10 millimeter. The 10 to 20 millimeter studies are still in pipeline. I had talked with some of the investigators and they showed extremely promising results for the stones even for 10 to 20 millimeters. Now this is an old study, this is from 2015. Now this is particularly nail in the coffin. It says that the PCNL is associated with higher stone free rates at the expense of higher complication rates, blood loss, admission times. Standard PCNL offers stone free rates superior to those of RIRS, whereas RIRS provide higher stone free rates than MIPPs. When added morbidity and lower efficacy of MIPPs, RIRS should be considered as standard therapy of stone less than 2 centimeter until appropriate randomized studies are performed. So as I said, the studies after this 2015 data were mostly based on holmium data. There are hardly any studies with thulium data, and we are awaiting that future. That future is bright. So incomplete clearance, right now we have evidence that is comparable. More data is needed from all of us. Every one of us should try and evaluate and really see whether it really works, because I believe it works and there is already enough evidence to try it. Expensive, that's a wonderful thing. So let's go into that. Any scope from Biorad, Hussain, HughesMed approximately cost around 80 to 90,000. If we consider 1 hour procedure time, that is actually a higher limit. One scope easily lasts minimum of 20 cases, more so in the hands of expert. So rough cost is around 3,000 to 4,000 cases max. Now I want to ask all of you one question. Can you tell me the cost of a renal function or kidneys, these are lost when patients went for alternative treatment, when you told them about a small cut in back? What if you told them about RIRS? Those patients might have saved their kidneys, might have been stone free. So can you really measure what is the worth of somebody's time? It is not, it's precious, you cannot define it. So expensive is a relative term. It is relative for a person. Let's not count patients' lives or patients' time in terms of money. So let's clear our mind. These are the arguments in place, this is the defense in place. The scopes won't pass, it will pass. The fragments will remain, just dust won't get cleared. Only if you think that it will always get cleared. There are no more long operative times. If yes, then only in learning curves. There is present data shows there is a comparative clearance as compared to mini PERC, and more data is needed from all of us. And as far as expense is concerned, think about somebody's life, somebody's kidneys. Now I am going to tell you why RIRS. It has no scar. There is very less chance of any significant bleeding. Reduce hospital stay. It is almost pain-free procedure. Try and palpate somebody's flank after PCNL and after RIRS, and the wince gives the answer to our question, why RIRS? Patient doesn't wince. It can be done in patients with bleeding disorders. It can be done in patients on antiplatelets. It can be done in patients with anomalous kidneys. It can be done in pregnant patients. The future is here. Now what? Are we going to be on this side of the screen, or are we going to be on this side of the screen? Are we going to the generation who has invented the wheel, or are we going to say no more wheel? Urology is the branch of science which is right now with it adapts the fast-paced innovation, and it becomes the part of it. We had come long way from open surgery to complete endoscopic surgery in just 4 decades. I believe many of the dignitaries sitting in the audience already has witnessed that. During their college life, they had done open surgeries, and now they are seeing RIRS and patients going to discharge in the same day. So let's invest in tomorrow's technology today. It is more critical than ever. Let's take that leap of faith. Let's believe in RIRS. It is the future. We are the change we have been waiting for. We have to change, then only we'll get data and we'll have constructive evidence. This is not debate. This is our past, which is blinding us from seeing, believing in a better future. Let's discard this past. Let's say yes to RIRS. Because we are urologists. We are first to imagine, make and adapt to the future. We are the first one who adapted lasers. We are the first one who adapted robo. And now we are here to define the future. Thank you. Thank you for your patient listening and time. Pranam. Okay, sorry. Just.
जिथं संपली त्याच्या पुढे चालू करायची. Nice pinky rosy picture. Nice pinky and rosy picture of future has been shown by Rajnikant, and I must say everybody must have great time thinking about the future. But let us come back to the reality now, because we are living in today's era, and what is today is that is important. Next. This video I have already showed the bloodless mini PERC. Next. There are a few injuries. I thought you will be talking about it, but all injuries can be managed conservatively. Solid organ injury. But how do you deal with these problems? So this is again a video of access sheath injury. You can see the access sheath injury, which is completely the ureter has been injured completely. Next. The flexible scope damage, acute bend, and in the case we can see the damage of the scope. As you said, 3,000 to 4,000 rupees is not a big deal. If suppose this is my first case, 80,000-90,000 has gone in the one case. See, look at that. Next. And of course, the rescue is always a PCNL. This is a case where RIRS basket got stuck, and it was removed by doing a PCNL. So next, I summarize by saying mini PERC, high stone free rate with minimal complications. It can be done day care. RIRS, less stone free rates, high recurrent rates, retreatment rates, and it is an expensive affair. Of course, supine mini PCNL and RIRS may be complementary in some cases, in cases of endoscopic ECHRIs. Thank you.
Thank you, Prashant. Now I would invite Dr. Abhay Mahajan sir, who is the moderator for this session, for his expert comment. Anything, Rajnikant, you have to, in rebuttal session to say?
I have already covered most of things. I had presented latest data, not at the anecdotal series which are like 10, 15, 20 years old. Everything is fresh, crisp and new. Either we try it or we just keep living in the past. And about that ureter access sheath, that answer is given in my very first study which I had quoted. We are here to discuss the present status, that is 7.5 French ureteroscope. Most of the ureteroscopes which we use for URS also at 6 to 7.5. The shaft is 7.5 and I am talking about those scopes. I am not talking about those scope which has been initially in the deal of making. And I would personally say the first person, for one of the first few persons who had bought thulium laser with the distinct possibility of its usability is going to be our moderator. And I am very happy for that because he is the guy who is going to say what is best. Is it best, sir, thulium? Is it really?
Thulium is good, but the debate is between RIRS and mini PERC. So, yeah, it is not between thulium. So, don't worry, I am just telling you. But see, now it's very simple. We are talking about a lower pole stone. Okay, the debate of mini PERC and RIRS for a lower pole stone will all depend on the anatomy of the PC system. RIRS is coming in a big way, so definitely it is going to stay. You cannot, these two procedures are not fighting against each other. They are complementary. I try to understand this. So these procedures are complementary to each other. So which procedure to select when you have a lower pole stone? This is the most important study and these are the most important factors you have to consider. If you consider these factors whenever you have a CT scan in front of you, it will be very easy for you to select whether you will do RIRS or whether you will do PCNL. Now this was what was proposed by Ilban C, where he said that you measure the infundibulopelvic angle. Okay, and there are three factors: infundibulopelvic angle, infundibular length, and infundibular width. Okay, and if the infundibulopelvic angle is more acute, if the infundibular pelvic width is narrow, if the length is more, RIRS will be a poor procedure. If the infundibulopelvic angle is obtuse, if it is not very inferior, almost parallel to the ureter, if the width is less, and if the angle is, the width is more, the angle is less, and the length is less, you can very easily perform RIRS for a lower pole stone almost till 20 millimeter. Okay, so these are the only three factors which will differentiate whether you will do RIRS or whether you will do mini PERC for a lower pole stone. Just study these three factors on CT scan. You can see also on a plain CT scan. You don't require a contrast CT scan to study these three factors. And what they have said that if it is a very steep angle, less than 30 degree, if it is a large stone size, and if the factors are negative, like less than 30 degree for a large stone burden, which all increases the operative time, then mini PERC is better and RIRS is a poor procedure to perform. But if it is a favorable anatomy, definitely you can do RIRS very easily for a large lower pole stone. Okay, so let us compare all the factors which both of you have almost mentioned everything regarding the intraoperative concerns and the procedural concerns. So stone free rate at present are low, and I'll tell you the reason why they are low, because the initial scopes were all fiber optic scopes. Now you have disposable digital scopes where the vision is so nice and excellent that the stone free rate is now going to increase in all the next publications which are going to come for lower pole stones, okay. So but at present the scenario is low stone free rate for RIRS in a lower pole stone as compared to mini PERC. Again, cost. This was all again the fiber optic scopes which were there, which were very costly, never lasted for more than 20 to 25 cases. I have used 3 fiber optic scopes till now, 3 fiber optic scopes. I have shifted to a digital disposable scope, which as Rajnikant has shown is very cheap and the vision is excellent. The overall cost to the patient is very, very low. Now there is no need for us to increase the cost of RIRS to the patient as compared to mini PERC. So this factor is also not very significant according to me. Yes, pre-stenting is sometimes required, so that is one of the negative factor of RIRS which you have to explain to the patient, which will increase the cost and the procedure. So both of the factors you have to consider when you when you do RIRS. Around 70 to 75% of the patient will be primary RIRS. 25% will require pre-stenting, where the scope will not enter the ureter with the newer smaller scopes. But still 25% is a big factor at present. So you have to keep in your mind that it might require a second procedure or a pre-stenting. Procedure time is more because the laser fiber is small. The laser fiber in mini PERC is big. The laser fiber in RIRS is small. The deflection is more, so you take some more time for fragmentation of the or lasing the stone with the laser. So it is at present more as compared to mini PCNL. Now this procedure time will also reduce when we start using disposable scopes, okay, because there is no risk of damaging the scope, and overall now there are plenty of studies. The overall cost of disposable scope will be significantly less as compared to the reusable digital scopes. Digital scope I am talking about, not about fiber optic. So the disposable scope will be cheaper than reusable digital scope. So again this time factor will reduce, okay. Need for repeat procedure, that can be there because sometimes the deflection, if it is more and you take more time, so if there are residual stones, we will have to do a repeat redo RIRS or a second look RIRS. Sometimes the accessibility is problem, but if you read the CT scan nicely and if you decide which procedure you have to perform, then the accessibility factor will also go down in RIRS. But in mini PERC that is not a problem. You can always access the lower pole, whichever angle it is with the as in relation to the pelvis. This we have already discussed. Damage of scope. So more likely, but again with disposable there is no risk of damage of scope. So you can easily use the disposable scope and just throw it off after 3 or 4 uses. So the overall cost of disposable is going to come down significantly. Complications at present they are more with mini PERC. Obviously this is a fact. The bleeding complications are more with mini PCNL and less with RIRS. So stone free rate and the complication rate, these are the 2 factors you have to consider whenever you are choosing any modality, whether it is RIRS or mini PCNL. That's all. Thank you. No. Not at all. Infective complications, now there are plenty of papers. There are the infective complications have significantly gone down with RIRS. There are hardly any infections that you see after RIRS.
Yes.
We never knew how to use lasers in ureter, especially. I am talking about in ureter. In kidney it doesn't matter much because in kidney there is a lot of space. Even in UPJ you can safely use it only if it is in upper ureter, and if you are using it with flexible and semi-rigid you can get strictures. But these were initial cases. That is going to go down significantly. because now we know what settings are to be used in ureter. Now we have a technique how to use in ureter and when to use in ureter and when not to use in ureter. That also one has to understand. Okay, so that is not a big problem. It is evolving. It is evolving. See, I have told you there are disadvantages of mini PERC and there are significant good advantages of mini PERC, but both the procedures are complementary to each other. You can choose any procedure depending upon the anatomy. That's the most important thing. Uretary strictures will definitely go down, Atul. And after 5 years, I don't think we'll see any strictures after laser. Because we never knew how to use the laser. Infective complications in RIRS have now significantly gone down because of good vision, less irrigation required for better vision. Initially, because of fiber optic scope, the vision was poor. So we used to increase the irrigation pressure, and that was the only cause of infective complication. There was no other cause. High intrarenal pressure, reflux of fluid into the pelvic lymphatic and pelvic venous channel, and RIRS and fever. That was the only cause of post-operative fever, urosepsis and RIRS. Now with good vision, there is absolutely no need to increase the irrigation pressure so high. With minimal irrigation, the vision quality is excellent and you can perform without any accessory supplementary instruments like a pump or a irrigation pump or increase irrigation with Pathfinder. So that is not required at all. Pathfinder is the worst instrument. I feel I have a Pathfinder. I'm just not using it since last 5 years. That is the worst instrument to increase the intrarenal pressure.
Also, the sizes of the scopes are also getting down.
Yes,
so the
yes.
efflux of the urine or the saline is also.
It will also reduce, definitely.
Sir, 1 minute, Abhay sir. We'll just felicitate you, everyone. So, we'll felicitate the team, presentation team, Prashant and Rajnikant and Abhay sir. I would like to invite Panitkar sir to felicitate a presenter and a moderator. नाही त्यांचं आहे सर त्यांची टीमचं करून एक फोटो घ्या Another team, Sudarshan, Aditya and Sharad sir, please come on the stage. I would like to invite Dr. Malik sir to felicitate our speakers and a moderator. Sir, please. Thank you. Now our president, Dr. Ajay Oswal sir, wants to speak something.
It was very heartening to see our members talking with references, studies and meta-analysis and articles and whatnot. So I really appreciate the hard work put in by each and every debater and the expert commentators. So he had chosen the topic. So I really appreciate the hard work put in by Arun to put up all this, contacting all the members and all the presenters and expert commentators who have put in a lot of hard work to make these presentations. Two things which I wanted to request all the members. We are open to suggestions. Anyone who wants to present anything or any topic of their interest can either contact Arun or me. We are easily accessible on a direct message. You can communicate your topic of interest. We can arrange to have a presentation on that. And what topics you would like to be covered in this next 9 or 10 meetings, we are open to suggestions. We have already made a list, but anything which you want to be covered, we can arrange that. Thank you.
Thank you everyone for joining us. I would like to thank the Pharma Alembic also for giving this very nice audiovisual, and also Ramesh Pawar, who is ex-Sigma IT professional now in MGM. Thank you, Ramesh.